final session of the day that's led by a 4-person panel. We have Ms. Megan Byers, Dr. Cheryl Dye, Ms. Caitlin Torrance, and Ms. Elizabeth Head, and they will be discussing how Alzheimer's disease data, including registries, guide community initiatives. So by way of introduction, I'll begin with Ms. Byers. She is the program coordinator for the University of South Carolina Office for the Study of Aging. She has developed policies and training curricula, monitored legislative sessions to determine their impact on vulnerable adults, educated stakeholders on issues of adult maltreatment and dementia, taught at universities, and is a published author. Next, we'll have Dr. Cheryl Dye, who will be joined by Ms. Caitlin Torrance. First, Dr. Dye is a research professor in the Clemson University Department of Psychology, a professor in the Department of Public Health Sciences, and the founding director of the Clemson Institute for Engaged Aging. Dr. Dye will be joined by Ms. Caitlin Torrance, who conducts primary research in areas that include aging, Alzheimer's disease and related dementias, and caregiving. She is particularly interested in health disparities that arise from the interaction of these areas and the healthcare system. And lastly, we have Ms. Elizabeth Head. Ms. Head is the Deputy Director for the Injury Prevention Program at the Georgia Department of Public Health. She coordinates the Be Seen Project for Georgia, which aims to strengthen Georgia's public health system approach to Alzheimer's and related dementias by building upon existing infrastructure across the state. Megan, please feel free to share your screen and begin your presentation.
Hi, thank you so much for everyone who has invited me here to speak and who those are interested in what we do. So I just have a few things I would like to clarify. Like I said, I'm from the Office for the Study of Aging, which is at the University of South Carolina. So I just want to summarize what we do. So I was already introduced, so we're going to skip that one. But the core mission of OSA, or the Office for the Study of Aging, is to prepare communities to meet the needs of a growing older adult population and to enhance the quality of life for these individuals as they age. The values of our office are groundbreaking research and strive to provide all findings in practical and usable formats. In addition, OSA facilitates research on aging-related issues to provide information to policymakers, deliver evidence-informed education on dementia, and to offer technical assistance for the development and evaluation of programs for older adults. So the OSA develops programs that are rooted in research and designed for application in the community as well as professionally. Projects and programs that are currently active include the South Carolina Alzheimer's Disease Registry, which you are clearly made aware of already today. The Arnold Aging Lecture, which is intended to promote healthy aging across a lifespan through current research by topic experts, is offered every spring without cost. Dementia Dialogues, an educational course for community members to learn more about the signs and symptoms of dementia. The Graduate Certificate in the Study of Aging is designed to address the educational needs of graduate students who will be and of professionals who are or plan to be engaged with older adults. The Graduate Scholar in Aging Award is to recognize graduate students who exemplify the highest standard of scholarship focused on aging. And finally, the Research Fellowship in Aging is designed to support faculty and professional staff within the Arnold School of Public Health to conduct research in the multidisciplinary fields of aging. So I want to focus a little bit on Dementia Dialogues, which is one of the biggest community education that we have within the OSA. So Dementia Dialogues is a nationally registered and evidence-informed intervention program. Evidence-informed refers to the use of existing research that is readily available that has been tested, tried, and true. An intervention program, specifically Dementia Dialogues, is designed to promote social emotional skills and mental health awareness for caregivers and organizations to provide quality of care and quality of life to persons living with dementia. Dementia Dialogues provides the most current and practical information about how to care for people with dementia. This 5-module training course is designed to educate community members and caregivers for persons who exhibit signs and symptoms of ADRD free of charge. Since 2001, Over 21,000 individuals have been trained in at least one module, and over 10,000 have been trained to complete have completed the entire course. Upon completion of the training, participants do receive a Dementia Dialogue Specialist certificate. Trainings are typically scheduled by level of need or when there are requests coming in, and the program is available not only in South Carolina, but also all throughout the nation. So before we get to that, you can see the 5 different module topics, and I want to quickly explain what those are. So module 1 is an overview of ADRD. Specifically, this module defines dementia and the types of dementia, identifies the prevalence of disease around the world in the US, and provides resources to identify individual state prevalence as well. This module continues to review warning signs of dementia, risk factors for developing the disease, treatment options, and highlights expected changes as the disease progresses. Module 2 discusses the importance of effective communication between a caregiver and a person receiving care. It identifies the barriers to communication as the disease progresses and communication strategies to overcome those barriers. Module 3 addresses environmental barriers for a person living with dementia and how to make the environment safe, whether it be home or a facility, as well as providing strategies for successful activities of daily living, or ADLs. Module 4 focuses on challenging behaviors for persons living with dementia. Specifically, this module defines what a challenging behavior is, identifies the most common challenging behaviors, and addresses strategies for overcoming these behaviors. And finally, Module 5 centers around developing a care team and problem-solving techniques for caregivers who provide care to persons living with dementia. This module reviews caregiver stress, identifies national resources and warning signs of adult maltreatment or elder abuse, and how to locate individual state reporting statutes and reporting procedures. So Dementia Dialogues is spread currently across 6 states with over 120 instructors. The programs are currently in Georgia, California, New York, North Carolina, South Carolina, and Utah. Persons who are interested in teaching Dementia Dialogues must complete a volunteer application, and if approved, complete a Train the Trainer course with me. This training is also offered virtually and is free of cost, depending if the training is in virtual or in person. As indicated, certified instructors are volunteers, meaning we have amazing people nationwide who are providing dementia education to organizations and communities on their own time. Our goal is to be in every single state. Lastly, on this, we are fortunate enough to announce that we were published in the Journal of Applied Gerontology earlier this year about our program of Dementia Dialogues. You are more than welcome to access this publication on our website, which is highlighted right down here. But I'm going to go ahead and highlight a few of the findings. So Dementia Dialogues participants tended to be female between ages 40 and 79, white and non-Hispanic. There tended to be an equal number of caregivers and non-caregivers in attendance, with majority of participants being caregivers in modules 3 through 5, with the majority of participants being, and non-caregivers, I see there's a chat, I'll check that in a minute. So caregivers are most common in modules 3 through 5, and non-caregivers in modules 1 and 2. Overall, every module showed a significant increase in score for the knowledge associated with the module. With the 2019 overhaul, we noted a few relatively minor changes during the analysis and the journal reviewer feedback that we would like to take in order to enhance the program. So some of the things we did were included additional demographic information, the type of caregiver, whether it be formal or informal, formal meaning they are services are provided by a fee, in addition to the amount of time they've been a caregiver and for whom they provide care to, such as an adult child, partner, sibling, so forth, and also moving to an online platform and module evaluations, individual module evaluations instead of one evaluation overall. All right, so the ADRD Registry provides extremely valuable information for community initiatives, such as, but not limited to, the program Dementia Dialogues. The registry allows us to analyze who is impacted and where they reside within South Carolina. Registry data forces us to ask those vital questions such as why, how, what, and when. We already know the who and where. By understanding what is occurring within our state, the more we can begin to help our communities, whether this be through community education, community forums, specialized community services, or even targeted services and education within those communities. So on your screen is a table of various statistics. So I think this is an excellent example of why we need our state registry. As you can see, South Carolina's registry allows us to identify the number of adults impacted with dementia and the type, gender, race, and those are just to name a few. Without the registry, states do not necessarily know anything about their state. All they can do is reference the Alzheimer's Association's Facts and Figures report, which is still important, but they don't always get an accurate look of their state. So for that example, the Alzheimer's Association's Facts and Figures report that there are 95,000 individuals aged 65 and older living with a type of dementia, whereas the South Carolina registry showed us there's even more than that, up nearly 120,000. So that is a significant and vital factor understanding and meeting our community needs. And I love what Lucy said, that using the data and take action, that's exactly what I was hoping to get through. We need that data to show this is why this area needs this service or this education. Without that data, we may not get approved for any type of funding to continue our research. So that is about OSA and Dementia Dialogues very quickly.
Right, thank you so much, Megan. Hey, Caitlin, I believe you're up and you're going to share the slides for you and Dr. Dye.
Yes, ma'am. 1 second. Hello, everyone. I'm going to start our presentation, and Caitlin and I are going to go back and forth with speaking to the slides that we put together. So next slide. And I'm going to talk about how we use data from the Alzheimer's Registry to bring attention to a need that we had in a couple of rural counties in the upstate of South Carolina, Oconee County and Pickens County. So again, it was a data-driven initiative to mobilize a partnership that resulted in 2-day programs for people with early to mid-stage dementia. Next. So we're going to talk a little bit about our larger framework, that dementia-friendly community initiative. And I've heard Taylor mention how all community members need to be involved with this. We'll look at that in a minute. And how we were able to collaborate and create a partnership to get a synergy of the resources that were available in the state that I don't think everyone necessarily knew were available. So I'll tell you our story. Next. Okay, so dementia-friendly communities, it says that businesses need to be involved, faith community, and just community members all need to be involved in making people with dementia and their caregivers feel supported and to provide them with the resources that they need. So I did hear Taylor mention the businesses, Chamber of Commerce, our legislators, of course. Our faith communities were involved in one of our day programs. We established that in a church. And then the community members themselves were involved, including our university students. And Caitlin, you can speak anytime when you advance a slide, but next slide.
Okay, thank you.
Okay, so as we know, people with dementia and their caregivers need support, compassion. They need to feel like they're still making a contribution to society and they have a purpose. So our day program is very much was individually driven, kind of a Montessori method, as Caitlin had this inspiration to describe it like that, so that we built on their current skills, help them become that person that they've, help them find that person they've always been. We had an engineer, we helped him with some building blocks on being able to create structures that made him very happy because he was used to building things. Another person had been a writer, and we let him share some of his writings with the group. So we found what was still there in that person that could be reactivated and shared with others. And it was truly joyful to see them feeling that they were still had a purpose in life. Next. So as you know, through the Dementia Dialogues that Megan just shared, there's a lot of things about dementia that people that are providing care and people in the community need to understand. So I'm glad we have some of those programs available, support groups, support and care management. But we're going to talk a little bit about the respite services that we felt was a need. So what we did with the data that was provided by the Alzheimer's Registry, we were able to show that just in Little Pickens County, there were 2,000 people that had been diagnosed with ADRD. And that was a real surprise for a lot of people. So we pulled together a group of stakeholders, university faculty, and the municipalities of Clemson and Central, the area agencies on aging, Alzheimer's Association community members. And we pulled that together and we talked about the need to serve those people with Alzheimer's and their caregivers. We did some asset mapping. We found that there was a closed senior center that could be reopened with enough funding for renovations. And we talked about, what was the need and how we're going to go forward. So with Caitlin's assistance, we wrote grants and the Alzheimer's Registry data was critical and into demonstrating the need. We wrote a grant for the Alzheimer's Resources Coordinating Center. Thank you, Taylor, for reactivating that center and Sheila Lewis for being the current director of that. We were beneficiaries of some of that funding. And we also got funding from the Department on Aging, a permanent improvement project grant in order to renovate this closed senior center. So we used a lot of resources and we could created a synergy so that we could maximize what we could get. And then we worked with the county where the senior center, closed senior center sat, and we had to get the land deeded from the county to the municipality. And then the municipality rented it to us for like $1 a year. And so there was a lot of coordination that happened. And then when we submitted for the PIP grant, after all of that, we were successful in getting that. So we used those funds to renovate the senior center, and we reopened it and called it a community center, which I think was key, because I think people want to see that this is just not a place for having older people. It's a place where the community can go. And actually, after we opened the respite or the daycare center or day services center, it also became an after-school center for elementary kids. And when it was decided that we needed to have the elementary kids come in the afternoon, we're thinking, oh no, we're going to have a bunch of kids running around, got to share the space. But it turned out to be a good thing. It was one of the big activities for our seniors who were there on Monday and Wednesday afternoons, was to go to the window and watch those kids get off the bus and come in. So it turned out to be a multi-generational type of environment, which was great. So we called our program the BrainHealth Club because it was all about building on the brain health of our participants, helping them achieve optimal functioning through not only cognitive activities, but social activities and fun activities.
Absolutely. Absolutely. The brain, I think it was important that we housed it in a community center, called it a community center, and then called it the BrainHealth Club, because people with Alzheimer's disease, they don't want to feel different. And when you house it in that sort of frame, it makes it much more welcoming to them. It makes it normal.
Yes. In fact, I love this story. One of the caregivers told me her husband would wake up on Wednesdays and go, oh, this is the day I go to the club. And in fact, that motivated us to make sure we use the word club in the name of this program. It's just so wonderful. So we went through the renovation and so forth, and the ARCC did help us out with 2 grants. One we had used in Oconee County, and that was the one that was established in a church. And then we used one in Pickens County to establish this in the reopened senior center. But I'm mainly going to talk about the one in Pickens County. So next. And so that was the old senior center that we renovated, reopened. We had a lot of university student involvement. Our architecture students developed a floor plan for how this renovation would occur. The AAA was very much involved. In fact, it became a satellite site for one of the senior centers in Pickens County. So a lot of people involved here. Next. And then we had the ribbon cutting, very exciting. Next. And, as before COVID, it was meeting 2 afternoons a week. Then it closed down like so many programs. It's reopened, but they're trying to build their participant numbers back up again. And I believe that that will happen. So it's been a wonderful thing to see. Next.
Yeah, I just want to take just a moment to talk just a little bit about the BrainHealth Club. We've already talked about why it was intentionally named, because we really want people to feel like they, even though you have dementia, you're still a full person. And we wanted it to not feel like a respite for caregivers. It is that, but it also is a place where people with this disease can grow and thrive and come together with their peers. We also worked really hard to tailor activities according to their interest. And Cheryl talked a little bit about people who like to read or write books. We would have a book club and that sort of stuff. But we really focused on stimulating environments and building social support. It was a club, it is a club for them. And it really does make them feel like they have a safe place in this world.
And then we talked a little bit earlier about workforce development, and I think that was one of the beautiful parts of this model. Clemson University students were in something called creative inquiry, which is where they're outside in the field doing work to support communities, solving community problems. And so they were health science majors for the most part that go on to PT, OT, med school. So these students got a real hands-on education working with people with dementia. Even though they might have been a little wary in the beginning, most of them really embraced the opportunity and enjoyed working with this population.
Absolutely. They were able to take what they learned in class and go into the BrainHealth Club, interact with the participants of the BrainHealth Club, and then they started to develop activities for the participants. And so it gave them a lot of ownership. And like Cheryl said, these people these students are going to go into fields where they're interacting on a daily basis with this population. And so that's wonderful. And we even had students who were talking about wanting to be pediatricians, turning around saying, actually, I want to be a neurologist. This is the population I'm passionate about. And so it's just this whole experience with building the building itself and using the architecture students and using public health students to lead the BrainHealth Club. It's like an extension of the university. It's a learning environment. It's just a fabulous thing.
Yeah. And Caitlin trained the students before they came into the day program. She trained them. And then, like she said, they were involved in Cradle activities. There we are with one of the groups in Oconee County. There's Caitlin, pregnant with her first baby. She's had 2 babies since we started working together.
Oh my gosh, I have.
Next. So again, I just wanted to summarize with the synergy that was created to use a lot of resources that are available. And then the Alzheimer's Association provided waivers to the caregivers so that they would not have any fee involved with this. And so we were able to provide these day programs for free to families because of the Alzheimer's waivers. And the Alzheimer's really supports respite waivers for group respite, and because they understand the benefit of having that interaction with the people in that group.
It was so helpful to know, about how many people in Oconee County or Pickens County are living with Alzheimer's disease using the registry, because that really helps us ground these initiatives in real fact. And it makes people listen, sort of like the data does talk.
Yes. And I think that's it. You want to go to your slides now? Okay, yeah. So anyway, it's a replicable model. And we did have an award, a national award for the BrainHealth Club, which was pretty cool. Okay, Caitlin.
Okay, and this is just the process, but we won't spend any time on it because we're getting a little low on time. But if you're interested in trying to set up one of these respites, we're happy to talk about it with you. It has been replicated with the Golden Corner Respite Care in Seneca. That was actually one of the first. The Rhodes Respite actually came first, right? And the ARC is a really good place for resources. A part of the reason that I'm here is I want to talk just a little bit about my doctoral dissertation. I've been working on it for ages, but I'm wrapping it up. And my goal was to look at emergency department utilization pre and post Alzheimer's disease diagnosis. And how this is traditionally done is using Medicare's claims data, where you go in and you pull a sample and you're like, okay, these are the diagnoses I'm going to use to identify an Alzheimer's disease patient, and then you follow them pre and post. Well, South Carolina, we are just so ideally suited for looking at hospital utilization and medical utilization because we do have the South Carolina Alzheimer's Disease Registry. So what I did was I actually requested ADRD Registry data for anyone who was diagnosed in 2014. And I requested South Carolina patient encounter data from 2008 to 2018, and I merged that data. So I was able to have pretty confidently assess the healthcare utilization of people living with Alzheimer's disease. The aims of my dissertation are threefold. The first is I really want to describe how those who are diagnosed with Alzheimer's disease, how they're using the emergency department in those years before and after diagnosis. Ultimately, I'm hoping to see if the emergency department encounters are different by subgroups. So are there differences by age at diagnosis or race or gender? All of those things, how do they influence or impact healthcare utilization at the emergency department level? Aim 2 is looking at the diagnoses and the reasons for those emergency department encounters. So I'm wanting to understand, what diagnoses are responsible for this? Are they potentially preventable? Are they things that you would expect to see at an emergency department or not? We know that Alzheimer's disease is one of the most expensive diseases for the healthcare system. And this is really trying to get at the why, what's behind that. Also, are there any, because I'm able to go back 7 years before diagnosis, are there any red alerts? Are there anything that, we kind of see in the data showing a pattern that, oh, if you're coming in with a UTI and this happens more than 2 or 3 times a year for multiple years, maybe that's a red alert for this person possibly suffering with some cognitive issues. Just some things to think about. And then the third aim is to explore charges, because at the end of the day, from my experience in different employment situations, cost is what really speaks. And so trying to look at the charges and determine why the emergency department is such a high cost venue. So why, what type of care are people with this disease receiving there, and is that appropriate? And if not, how can we adjust or shift to help people receive the right care at the right time at the right place? And so ultimately, the goal is to improve healthcare for persons living with Alzheimer's disease or related dementia. Right now, we can't stop the disease, and we know that at the moment. That will probably change at some point, we hope, but right now we can't. But we can work together to better manage it. And also, it's probably important for the system to recognize, I'm hoping my data will show that the system cannot assume that patients with Alzheimer's disease are able to sort of manage this on their own. So we really do need to start looking at exploring different models of care to support people with Alzheimer's disease and their caregivers. So this is just a very preliminary graph, but this is just showing, that's my timer, time is up, but you can see here the differences in the average number of emergency department encounters over time by race and gender. Okay, thank you so much.
Great job. Thank you again to both of you for sharing your time and presenting with us today. So we are going to round out our session, our final session, with Elizabeth Head. If you're ready, you can share your screen.
Yes, ma'am. Thank you so much. There we go. Can everyone see my screen?
We can, thank you.
Lovely. Really appreciate the other panelists, their discussions on their programs. It's been such an enlightening day all the way around. My name is Elizabeth Hadden. I'm the Deputy Director for Injury Prevention at Georgia Department of Public Health. We want to talk about today our Be Seen work, using data to guide community initiatives. This slide will seem a little familiar to you because Rana presented on it earlier today, and it bears repeating to an extent because this is really where our use of data from the Alzheimer's Registry began in earnest in terms of really developing the community initiatives and workforce development and other types of things that we're working on now. So in 2013, when the General Assembly created and passed both the Alzheimer's and related dementia state task force, which of course allowed us then to create our first state plan for Alzheimer's disease. They also recommended that establishment of the ADRD Registry. Important to this point is the fact that our partners involved public health in both the creation of this task force and the registry, as well as that initial state plan document. They really specifically wanted public health involved. And those are some folks at our Alzheimer's Association, some are folks at our State Plan on Aging, just really felt that public health and the type of data that we are able to help them with was important to the efforts that they were doing in that living document. And of course, at that time, there was the allocation of a little over $100,000 for that establishment of the registry. That funding was actually also secondarily marked to bring in future funding. So take this funding, make the registry, use that data and that funding to help bring in additional dollars. And we're really excited and proud to say that we were able to do that. We are one of the 5 enhanced awards through BOLD. Our particular project, when we say Be Seen, it is BOLD, using systemic education evidence and networks. And that's because we want Georgians to be seen. We want the caregivers that work with them and to help them to be seen. And we want the professionals that serve those two populations to be seen and for all of them to feel connected. So our overarching goal in Georgia is to get to earlier diagnosis. And everyone here is familiar. Of course, we want to do that through addressing risk and protective factors. We're doing that through public, private, professional messaging and data synergy. So it's not just about our Alzheimer's registry. We're incredibly grateful for it. Rana does and her team in EPI does such a phenomenal job with that data. It has really informed our entire application for BOLD. It has informed our focus areas across the state. It has informed the need for other types of projects, one being a telehealth partnership between ourselves and the Georgia Memory Net. You may remember from this morning that Georgia Memory Net has 5 memory assessment clinics across the state. Those memory assessment clinics feed into our registry. But in addition, through that partnership, we were able to realize that because we are a 159 county decentralized state, in our rural areas in particular, where there's high burden, a lot of unevenness to how people are cared for, that it was important to try and create an additional way for people to be seen for follow-up visits at the Georgia Memory Net's assessment clinics. And so what we're currently working on is a tablet project where a tablet physically sits in several local health departments, and that health department will work with a memory assessment clinic from anywhere in the state, serving people that may live close to that local health department that need to be seen for follow-up care at the memory assessment clinic. And so that person comes into the local health department. The health department receives an origination fee, which generation of fees to pay for time is important. And then they have their telehealth visit with the memory assessment clinic, thereby opening up the just overall availability of our memory assessment clinics, which are so important to diagnosis and care beyond diagnosis, as well as setting our public health workforce up to really participate in a tangible way with this. And we wouldn't have gotten to any of this without being able to show where in our state some of our issues were. And we did our Alzheimer's registry, particularly our Medicare data, as well as our hospitalization and death data to do that work. You're going to have also seen this twice today, actually. Was so motivated by Dr. Thorpe's presentation this morning and appreciated the shout out to our product from 2015 around perceived cognitive impairment. We've utilized BRFIS, we've utilized our Alzheimer's registry data to create a couple of these reports. And it's been really helpful for professionals across the field, which is what we want to do. We want to inform professionals and we want to inform caregivers so that they have as much information as they can in a way that makes sense to them. In addition, our data has really helped to inform the second iteration of our Georgia Alzheimer's and related dementias state plan. The first plan was lovely. It was a labor of love by well over 100 people, probably closer to 200 people, an absolutely massive undertaking for a state that hadn't had something before. But it was a plan of passion projects. And a plan of a group of passionate people created those passion products, and we created work groups and went from there. And it's been lovely, and it's a living document. So we've made some changes to it as we've gone along. However, this second iteration of the state plan is truly data driven. It is SMART objectives, no more than 3 objectives per 3 activities and strategies per goal for each of our workforces. And we are moving forward from that to teach all of the professionals and advocates and just other wonderful partners that we have that are part of the GUARD Collaborative to use the data that is available. And we'll talk a little bit more about that in a minute. So we're really proud that this state plan is so data informed and data driven as we set up some really tangible markers for people to have success on moving this work forward in our state. Some additional products that we've been able to create as a result of our Alzheimer's registry and that whole collective of data that we have available to us. First, of course, is cognitive decline in Georgia in 2019. That data is taken very specifically from BRFIS. However, one of the things that we've discovered, and very much to Dr. Thorpe's point from this morning's presentation, is this beautiful purple and blue and white document does not speak to a community. It doesn't. And so we also created a document and an entire media campaign in Georgia called the Think About It campaign. And it makes more digestible talking about risk, talking about what it is that you might consider when you're thinking about what's happening with you or your family member, or just in general, someone that you care about. So we've used data to obviously inform and get really down into our numbers. We've also used data from our communities to inform more creative, more specific products that may mean something to them. And as much as we love this fact sheet, the thing that we really love in Georgia, and I hope that everyone can see this, is we created something called a Z card. Hopefully on your screen, this looks like the letter Z. If it's backwards, I'm sorry. This is a Z card, and all it does is open up into an 8.5 by 11 sheet of paper that has some of the same information from that red and white fact sheet. But because it's presented in a different way, folks are somehow more open to it. And so we've tried to think about those really simple types of innovations to better present the data that we have available, since we're so lucky to have so much data in Georgia. In addition, thinking very specifically to getting around to earlier diagnosis. BRFIS in particular has been very important in helping us understand where in Georgia we need to focus. So those respondent questions for folks over the age of 45, we did a subset of that from 45 to 54 and understanding where in the state that they might be, so that we know that maybe we're not contacting the area agencies on aging. Maybe we're talking to primary care physicians, because your 45 to 54-year-olds are still working. Frankly, so are the 65-year-olds at this point. But maybe you're going into rec leagues and you're talking with some other people and you're reaching out to extension offices, folks that are part of active families' lives, to help them understand where their risks might be and where they may lower those risks. So that's been a really great thing that we've been able to do in the state as a result of the data that we have. In addition, going back to a point I was making earlier, training our workforce getting them to understand the data that is available and getting them access to the data that's available. Rana had a much prettier graphic of our state online analytical statistical information system earlier today. However, right here at the very bottom of this photo, you see the behavioral surveys, and there's behavioral risk factor survey. We have the general modules up right now. What we don't have are our wonderful alternating years of odd years for perceived cognitive impairment and even years for caregivers. We're currently working to get those modules in aggregate up onto our public-facing website so that professionals can use that data in their planning. Everything that we've produced has been gobbled up by our aging network, our public health network, as they're looking to see what's happening in their part of the state. So we've made the decision and are able to get that up onto our public facing website, and we're very excited about that prospect. Speaking specifically about workforce development, one of the things that we've learned through some needs assessments and environmental scans is that particularly public health professionals, and I do think that the pandemic has had something to do with this, just how much it is that they have going on and how is it that we can break into that kind of line of vision of what they've got their eye on. And there's a couple of ways of doing that. So we're taking something that exists in Georgia. It's called Virtual Dementia Tour by a nonprofit called Second Wind Dreams. And we are training some professionals around the state to do it. And those folks are going to be running not just members of the community, because this is typically an immersive experience for members of the community. And we'll do some of that. But we very specifically want to hone in on professionals in the field, particularly public health folks, first responders, EMS, fire, police, all those folks. And we want to run them through that 15-minute immersive experience. And we are following up with a 1-hour engagement discussion on how it is now that you have this new perspective. How do you then incorporate that perspective into your work? So how are you incorporating it into your emergency planning? How are you incorporating it into how you interact with someone who may have some type of symptoms and may or may not be diagnosed as of yet? So we're really happy to be working with that. We are utilizing existing folks through GARD and Emory to put things up onto our state training system. So it is a systems approach. We're really excited about that. And for folks still in trainings, thinking very specifically about our schools of public health, our university system around Georgia, making sure that they know about already developed curricula specific to public health, for new public health professionals around what is dementia and Alzheimer's disease. Where are the resources? Who are the other professionals doing the work? Those types of things, because there's a lack of that, and we want to make that robust so folks know where to go and how to find information to help them in their careers. This, of course, and all the fabulous maps that have been created and the fabulous tables that have been created through our Alzheimer's registry has led us to really double down on our rural outreach efforts. So we've partnered with the University of Georgia. If you're a dogs fan, awesome. They have Osher Lifelong Learning Institutes, not just in UGA, but in universities around Georgia. And so they've piloted a curriculum looking at adult learners to help them understand brain health, not just doom and gloom, risk factors, what's going to happen, how you might suffer, but really thinking creatively about brain health and what the needs are. They've also gone into in partnership with their Archway group. Archway does socioeconomic work in rural Georgia, all throughout rural Georgia. So they're taking that socioeconomic group and they're partnering it with our friends at UGA and their brain health group. And they're going into extension offices across the state and talking with those local communities, much to Dr. Thorpe's point this morning. How do you want to receive information? What are your concerns? What are your needs? Sometimes it's falls. Sometimes it's older driver safety. Sometimes it's I'm still farming and I got to work. So how are you going to help me be safe? It varies. And so then coupling that with some discussion around brain health and sort of this a la carte menu of available resources all of which are being cataloged as part of their interaction process with these rural communities, which has really, really been fabulous. The thing that I think I love the most is that part of that interaction has led us to a phenomenal partnership with Alter. Alter is really looking specifically at a lack of resources and awareness around dementia and the Black American and faith communities here in Georgia. And so we've connected UGA and we've connected Alter, and they're now working together to work with African American churches in our rural populations across the state. And they're starting with basic things. Dementia friendly, being inclusive, but they're also bringing in caregiving modules, caregiving curricula, caregiving while Black, Savvy Caregiver, which is a program developed here in Georgia by Emory. And so we're really fortunate to have both partners that are maybe doing one thing and are willing to pivot a smidge and go in these other areas of the state where they're needed and connect with one another, which has been particularly exciting. So what I want to leave everybody with is this is one of the graphics from our Think About It campaign. If you can't find the right word or if you can't connect with people in relationships the way that you have previously, or if you're noticing that about a loved one, maybe it's time to think about your brain health and things that you could be doing to be as healthy as possible, both in your brain and in your body. But connection, no matter what is happening, is always really critically important. And we do that primarily through our use of data. So really happy to be here. Really appreciate everyone's time. If you have any questions, please feel to reach out.
Great. Thank you so much, Liz. And thank you to all of our panelists today. Really, again, a great way to round out the discussion. And many of you were reflecting back on our keynote speaker and how really the work that he described and a lot of the initiatives that he implored us to take really are reflective of the work that you're already doing. So thank you guys for that. I know in the past I've kind of used the opportunity to summarize the things that mostly resonated with me. And for me, with this last panel, it really was that data can inform the need for initiatives, projects, and campaigns. And so for many people, I think we approach the idea of data as daunting, but you guys have really done an amazing job of demonstrating how we can truly use data to inform the good work for the populations that are most in need. So thank you all again. So if you do have any questions, please remember to put them in the Q&A field. We do have one question for you, Liz. It says, Liz, how have you studied the effectiveness of that Z-card material? Is it generalizable to other states? Is the intended audience those with ADRD or their caregivers, or the general public for prevention?
So we're actually right in the middle of the process of evaluating the Z-card specifically. The media campaign that we ran was really successful. Our communications department measured not just the number and type of interactions, but generally speaking, how people felt about all of the campaign materials as a whole. So we're still working on this using focus groups. And I think there's probably a couple of tweaks that need to be made. In terms of audience, we actually have two of these Z-cards. One is for the general public. It could be used for caregivers or for someone with any type of risk factors. The other one of these cards is blue, and all the information is the same, except one corner of that Z-card actually has the CPT code needed to bill once you've assessed somebody for some type of dementia. So that's how we break down the audience for the cards.
Great, thank you. Any other questions or comments? Much of the information in the chat is making connections and networking. At the very beginning of the day, we asked folks to type in the chat from where they're joining us. And so we saw that we had some great institutional partners in other states in our region. And so it'll be great if this is an opportunity for a burgeoning relationship. So good to see that communication happening in the chat. But any specific questions? Here's one. How are people using social media for their work? So that can go out to any of our panelists. Caitlin, Cheryl, Liz. Megan, any ideas for using social media in your work?
Yes, so we're lucky enough that we have someone dedicated to all of our social media within the Arnold School of Public Health. And we have regular scheduled information about Dementia Dialogues, and it links them to our website. So it's like, hey, if you're interested in this training, here's more information, here's contact information, so-and-so. But it's been a great resource getting to younger generations, specifically for Dementia Dialogues, because as you saw, our not our target, but our average participant is 40 to 79. So we need to start getting those younger generations in so they can start being aware of what's going on. Could this happen to me? Or will I be a caregiver? So I think social media is a great platform to getting the younger generations, but we do have older generations on social media, and that also helps to get them thinking as well.
And I can add that the BrainHealth Club is marketed through the Pickens County Meals on Wheels, which is a senior center, the main senior center in Liberty. And then that central site that we reopened is a satellite center. So they market the BrainHealth Club through their social media outlets.
And piggybacking on that, I mean, I guess Facebook is a social media outlet, but when we did focus groups with older caregivers, that they didn't view it as social media, but they felt like it was something that they would use, they were comfortable using. So still Facebook is a really good way to market to your 70 plus.
That's great, and I'm glad you added that bit about the demographic, because I know that it skews differently with different segments of our population. So yeah, I would agree. I think for the demographic that's of interest for folks who are interested in working with this population for our conference, certainly that would be a good option. Other ideas or questions? We have had a full and fruitful day for sure. Seeing none, I am going to end with a few closing remarks. So as I mentioned, we truly thank you so much for spending your time with us today. Thank you to the attendees. Thank you to all of our speakers. Thanks to all of you for joining us today. And we do hope that you had an enriching, I think, Liz, you used that word, an enriching experience during your time with us. Before we do close, we have a few brief announcements. The first is that you remember that we love data. We also love evaluation as researchers and practitioners. So you will each receive an email from the conference center with an evaluation survey that'll be attached to it. We do value your feedback on this experience and highly encourage each of you to complete this very brief survey. Number two, now that you all know all there is to know about our National Alzheimer's Disease Registries, we do want to encourage you to use these amazing clearinghouses of information. Affiliated with the conference is a mentored interactive workshop for underrepresented minority scholars with a terminal degree who are interested in developing a research project using Alzheimer's disease registry data with the support of a mentor. Scholars who are selected will complete their project over the next 12 months and be invited to present their research at the next annual National Conference on High Impact Alzheimer's Disease Registry Research. To learn more about this opportunity or share information with us about people who you think might be interested in this, please do contact our program coordinator, Mr. Quentin McCullum. And I'll ask that we put that information about how to contact Quentin in our chat. His email address is mccolluq@email.sc.edu. You can also find out more information on our website, and that is www.sc.edu/ccadmr or CADMR. And lastly, we value community. And if you want to learn more about the work that we are doing as part of the Carolina Center on Alzheimer's Disease and Minority Research, please email Quentin to join our listserv. So lastly, on behalf of my colleagues, Dr. Sue Lefkoff and Daniela Friedman, and our conference planning committee, I would like to thank you for attending our inaugural National Conference on High Impact Alzheimer's Disease Registry Research. And thank you to our funder, the National Institute on Aging, for supporting this year's conference. We ask that you have a safe and healthy weekend. Thank you.